Thank you both for excellent presentations. Maybe we'll take 2-3 minutes of questions before the break. And maybe I'll start with one question for Sumera. Have you yet looked at the combination of targeting PD-1 or PD-L1 and TSF1R in your models?
Yes, so that study is ongoing, and we plan to analyze the tumors using CyTOF, so we get a deeper understanding of the different immune cell subsets. So not just the macrophages, but other immune populations such as MDSCs, regulatory T cells.
Excellent. You have a question here?
Yes, thank you for the presentations. They were wonderful. Just a quick question. Many patients throughout their journey will go through various different types of chemotherapy treatments. They'll try one will work better than another, then one won't, and then they'll try another and another. In immunotherapy, I realize it's newer stage, but if a patient does not respond well to an immunotherapy treatment, do you envision that down the road patients will be trying different types of immunotherapy treatments? And are there benefits to trying multiple types?
I'll ask Dr. Kelley to answer.
I think that's a fantastic question, certainly one that we're already seeing in the clinic, whether it's with cholangiocarcinoma patients in clinical trials or in liver cancer patients where we have multiple drugs now approved. I think that's the kind of trial we need to be doing, and it's another opportunity for collaboration because it's not as attractive of a study to conduct from a strategy perspective in getting a drug approved, but it is absolutely the question we want to answer. If you start with monotherapy and don't progress, can we add a targeted agent or add a second immunotherapy and try to initially start with something simpler and less toxicity, and then if it's not working, add something else? I think that's exactly the kind of question that we'd like to answer. If possible, to model it in a laboratory setting, but I think it's really hard to answer these human immune response questions preclinically sometimes, and so we need to try to develop trials to answer that question, because right now I don't have an answer. I don't know, Anthony might
No, I agree,
have something
fully
else to
agree.
add.
Yeah. This microphone.
Thank you. I think part of the problem is that as rare as genomic testing is, having PD-L1 testing is even rarer, that it doesn't come automatically with your Foundation 1 request. You have to specifically ask for it. So that's even fewer patients that are finding out if they have a PD-L1. Is there another way to test such if a patient has, or to have an indication that immunotherapy might be appropriate for a patient, such as if that patient had an ALK mutation and a POLE mutation, POLE, even though that patient would be MSI stable with a low tumor mutation burden?
Well, we don't actually know yet the true implication of PD-L1 status on immunotherapy response. The Keynote 158 trial showed a slightly higher response rate, but the numbers were too small to be significant, and the rest of the studies have very heterogeneous availability of the results, as well as different modalities for testing different antibodies, different scoring systems for which cells are being tested. So right now it is not helpful to know whether and that's just even on top of the fact that tumors are heterogeneous and it's potentially a plastic marker that could change from an archival biopsy to the time point you actually need the result. So there's a lot of challenges to interpreting PD-L1 in cholangiocarcinoma archival tissue and from the data we have. So right now, it would not impact my decision whether to use an immunotherapy in cholangiocarcinoma.
I fully agree. I mean, because PD-L1 has not been a reliable predictive marker across tumor types, let alone in cholangiocarcinoma, where we actually don't know quite yet. It's likely that ultimately we're going to need some sort of composite score to predict who's going to respond to immunotherapy, especially in cholangiocarcinoma. Yes, next question.
I have a quick follow-up to that first, to Katie. So, but did you say that even though PD-L1, that may not be associative with a good result to an immunotherapy, MSI high is much more reliably a predictor, or we're still not sure of that?
So MSI high has shown a strong relationship with higher response rates across solid tumors, and that's what led to the FDA approval of pembrolizumab for MSI high or mismatch repair deficient tumors, considering those to be somewhat interchangeable right now. So yes, if one had an MSI high or mismatch repair deficient tumor, that would be a strong indication to consider immunotherapy.
And that one study you said that just was done at GI ASCO of GemCis plus the immunotherapy drug, was that cohort, was that all MSI high, or was that?
No, they did not report MSI status from that cohort, which is, again, one of the challenges in interpreting the data we have is not all of them include all of these biomarkers yet, and so it's early, incomplete data. But one can assume it's probably in the 2 to 3% range
Okay, great.
if it follows the normal
And your
incidence.
suspicion, though, is the MSI high is, even within that study, probably partly what's driving some of the success?
We don't know. I think in that study, the numbers, there were 30 patients, and so it's unknown what percentage of them had MSI high, but probably not more than a few.
Okay, great. And then real quick, my other question was, when you were going through your awesome slides, you had to very quickly go over something that referred to peptide vaccines. And I know in Europe there's more talk on that. Could you just spend 30 seconds on that?
That slide is showing what maybe will be a topic for a year or two for now. Right now, we don't have specific cholangiocarcinoma data for most of the sort of beyond checkpoint inhibitor approaches, certainly to my knowledge at least. But there are multiple, across tumor types in oncology, there's a huge interest in finding ways to achieve an immune response in people who don't get one of these responses or who from checkpoint inhibitors or who progress on checkpoint inhibitors. And one such strategy is either tumor-derived peptide vaccines or mRNA vaccines, which are sort of a similar idea. There are clinical trials of these, but none specific to cholangiocarcinoma at this moment, to my knowledge. There may be cohorts in development in the future.
Dr. Knox just whispered something in my ear, which is a very important point in clinical care, is that for MSI testing, one doesn't necessarily have to wait for the entire genomic testing to be done, because this is an immunohistochemistry test that can be done even locally. So that's a faster turnaround test that can be obtained and is important, and again, as Dr. Kelley mentioned, in this disease. So next question. I think you were first. Okay, you were first, sorry.
There is a lot of discussion about PD-1, PD-L1, a little bit about CTLA-4, but there's a handful of other things like it out there. GITR, IDO, a whole bunch of CDs, 40, 137, and so forth, that really bat those mice tumors down. And I see trials coming up about them. Are there any results yet or encouragement for the future for GI tract cancers?
So I'll take a shot at this and see what my colleagues want to add. So as you alluded to, a lot of the development of immunotherapy combinations is happening in tumor types other than cholangiocarcinoma. It's usually mostly in the common immunogenic, more common tumors like melanoma, non-small cell lung cancer, etc. And unfortunately, many of these IO-IO combinations, immunotherapy combinations, are struggling because I think without a way to select patients appropriately, these sometimes random combinations are not paying off as frequently. So it's a challenge, and I think in cholangiocarcinoma, hopefully through models, we start learning exactly which other checkpoints are important drivers besides PD-1 or PD-L1 to make more rational combinations. But you would like to add in?
So, and that's why I mentioned CyTOF, because through CyTOF we're also looking at other checkpoint molecules such as TIM3. And our goal is to really delve deeply into the immunobiology of cholangiocarcinoma, so know which immune subsets are important, and to know when we do try different treatments, combination treatments, whether there's a population that emerges and causes resistance to that combination, and so we don't get a good tumor response. So those are all of our goals, and that's why we're excited about this model, because it is a very quick model. It's 4 weeks, so we've been able to do a lot of these studies fairly quickly, and over the next couple of years, I hope to be able to test more combination therapies in our models.
Next question.
Yeah. Do you see any role for immunotherapy in cholangiocarcinoma patients who have coexisting autoimmune diseases?
Katie?
I think right now the concern is, obviously for spurring a worsening immune reaction to your own autoimmune disease and causing a flare of inflammatory bowel disease or colitis or whatever the the underlying autoimmune disease may be. And then coupled with that is the challenge of us not quite knowing yet how immunotherapy fits into cholangiocarcinoma. There's no FDA-approved drug for cholangiocarcinoma as yet, and we're all working completely within early phase clinical trials, which we hope will lead to future randomized phase 3 trials. But I think if one had a very strong indication for an immunotherapy drug, for example, with mismatch repair protein deficiency or high microsatellite instability, and an autoimmune disease and a life-threatening cancer, in such situations where I've had patients, I've considered it with their rheumatologist or their gastroenterologist or whoever is managing the autoimmune disease, and in a couple cases have used immunotherapies in patients with autoimmune disease under close supervision, with it as well controlled as possible in advance. But I think that those are cases that have to be, really carefully considered on an individual basis.
Okay, I'll ask you both one last question before we break. How much do we know about the difference of the immune milieu depending on the subtype of cholangiocarcinoma? Do we know if there are differences between intrahepatic, extrahepatic, gallbladder at this point?
Our models are all intrahepatic, and there is no mouse model of perihilar cholangiocarcinoma.
Right.
So from, in terms of what we learned from the mouse models, we would just know in terms of the immune milieu in intrahepatic cholangiocarcinoma. But the tumor microenvironment is more homogeneous than the genetic profile of the different subtypes. So I'm hopeful that we would be able to what we learned from the intrahepatic tumors, that we can apply that to the other subtypes. But
I think they're very different immune microenvironments. In the background liver, as Sumera presented so nicely, it's a very unique profile of immune cells like Kupffer cells and NKT cells and a host of cells that may modulate the immune response differently than the distal bile duct. And so I think we can expect there would be differences in immune response, which is why it's very important. Again, a reason to try to do a retrospective analysis, at least as a starting point, to look at a simple metric like response rate according to location, because there may be very different features of these tumors.
All right, well, thank you all for your attention. Thank you for both speakers. Enjoy your break. We will regroup here at 4:15. Thank you very much.